Get started. Good morning, everyone, and welcome to our 9th Women's Health webinar series. My name is Dr. Nazanin Homafar, and I'm an obstetrician and gynecologist at UCSF. Today, we'll be talking about updates to prenatal care at UCSF during the COVID-19 pandemic. I've continued to see prenatal patients in clinic and our labor and delivery unit through our initial shelter in place in March. And I have to say, it's remarkable to pause and realize we've been in this for 8 months. I don't think we ever imagined it. And I know it's come with a lot of changes to our lives, but we're still in it. And we're grateful for all the work our patients have done, the community has done to help keep us as safe as possible. We started this series in April when we realized we would need to make changes to care delivery to protect our patients and healthcare providers from the potential effects of a pandemic. Today, we're going to discuss updates and research studies on pregnancy and COVID and hear from my colleagues about updates on how we are delivering our care in the clinic and hospital. While we prepare to introduce our speakers, please help us get a sense of who is tuning in today by filling out this poll. Bertina will launch it. I'll give you all a minute to fill it out. And while we give you a chance to respond, I'd like to introduce our wonderful panelists and give you insight as to how we'll use the hour. Dr. Stephanie Gaw is an MD, PhD, and assistant professor of maternal fetal medicine. She's the co-principal investigator of the Priority Study and co-investigator of the Aspire study. Dr. Roxana Irani is an MD, PhD, assistant professor of maternal fetal medicine and the ambulatory executive medical director for Women's Health. Dr. Juan Gonzalez is an MD, PhD. As you can see, our panelists love an education. Associate Professor of Maternal Fetal Medicine and Associate Medical Director of Labor and Delivery. Let's see our poll results are so far before we get started. So always love getting these results. The majority of you today are in your second to third trimester, so 15 to 27 weeks. So one of you is postpartum. Thank you for joining us. 3 of you are thinking about getting pregnant, and we really hope this will be useful for you. And the rest of you, we have maybe a few months to a few weeks to continue helping deliver your care. So we're so excited you joined. 43% of you have previously watched a webinar, and this is really exciting to me. The majority of you have not seen one of our webinars, so hopefully this will give you an introduction to what we're trying to do. And actually, I'm going to take this opportunity to tell you all that this is, as I mentioned, the 9th webinar series we've done in women's health and updates in care and COVID. We are going to, Bertina will send a link of where you can find our previously recorded webinars. And I hope you'll all take a look at the Zooming Through Pregnancy to Parenthood webinars, which were designed by our incredible midwives to give you snippets of information that otherwise you might have received during a centering group. These are supposed to be topics that are very relevant during pregnancy, and you may only have a few minutes to discuss it in a prenatal visit, but then you have an hour of full education that you and your partner or your friends can watch with you. So please check those out at some point. If you ever have any thoughts on other topics that you'd like to see covered, you're welcome to reach out to us and let us know. Let's get started on today's topic. Many of you have sent great questions ahead of the webinar. We've reviewed them, and we will be addressing many of them during today's webinar. I'm so sorry. Rule number 1 when you're hosting a webinar, make sure everything is muted, which I did not. And for those of you who may be wanting to rewatch or share with the webinar with other friends at UCSF, the recording will be available online in a few days on our website. We'd really like to use our 45 minutes to discuss updates on research on COVID-19 and policies at UCSF. We'll have 10 minutes at the end for questions, and some of our panelists may choose to answer the questions that you are sending in throughout the webinar. So without further ado, let's get started. I'd like to start with Dr. Stephanie Gaw. Dr. Gaw, you joined us in July for our webinar on research studies on COVID-19, and you had explained to us why it's been challenging to understand implications of COVID-19 in pregnancy. You, along with others, recently published a study in the American Journal of Obstetrics and Gynecology titled Clinical Presentation of Coronavirus Disease 19 in Pregnancy and Recently Pregnant People. Can you give us, tell us a little bit about this study and your key findings so far?
Yes, thank you, Naz, for inviting me back to speak again. So this publication came out a couple months ago, and it was one of our first publications from the priority study that I'm one of the principal investigators on that we are leading out of UCSF. And this is a study of pregnant people that are tested for COVID-19 in pregnancy. This is a national study, so we have recruited patients from all over the United States, with the exception of, I think, 2 states. So we have full representation from the entire nation. And this first paper was to describe what the clinical disease was like in pregnancy. We all know that, there are many symptoms of pregnancy, and a lot of the symptoms of COVID do overlap with what we would consider regular routine symptoms in pregnancy. And a lot of times for everyone, it's hard to understand what would be the most concerning symptoms that would be more likely to be COVID versus not, and how these symptoms evolve over pregnancy, and whether or not pregnant people, since the immune system is different, may have different symptoms than non-pregnant people. And this is obviously a collaboration with many groups. The first author is Dr. Ayalda Afshar, who's my colleague, maternal fetal medicine at UCLA, and the other co-investigators on the study. Next slide. So this was one of the first publications. So looking at our first participants that enrolled in the study early on. I'm sorry, Bertina, can you do the next slide? Oh, great, thank you. So this was with the participants that were enrolled early in the study from March 22nd through July 10th, 2020. At this point, there were 736 participants that had data available for this publication. We wanted to know what percentage of the participants that enrolled and that were tested for COVID did come back with a positive test, why they were tested, which symptoms they presented with, whether they were tested because they had an at-risk exposure. And then we followed the patients for 4 weeks after their enrollment in the study to understand how their symptoms evolved over their initial disease. So in total, there were 736 participants. Almost 600 were COVID positive, and 142 tested negative for COVID. One unique thing about this study cohort that we're following is that 95% are not hospitalized. So if you're reading the news articles or following the data in the literature, the majority of other studies have been on hospitalized patients. So either hospitalized for labor and delivery, so at the end of their pregnancy, or quite often the very, very sick patients. So I think this probably gives a better representation of the general presentation of COVID-19 in pregnant people.
And if I can just pause for a second, because I think this is a really important point. So in your study, 95% of the patients were not hospitalized because of symptoms of COVID?
Correct. They may have had symptoms, but not severe enough where they needed to be in the hospital for monitoring or treatment of any kind. So, and this is what we know is now is the majority of people that get COVID are at home and self-quarantining, right, and overall do well. And a smaller proportion of them are in the hospital. So these are 95% of all participants and 95% of the COVID positive as well. It was equal across both groups. When we look at, there's a lot of stuff about risk factors. So pregnancy is a risk factor for more severe disease. We do know that now based on more recent data. But from the beginning of the epidemic, we were also hearing about other medical risk factors for more severe disease. So in these pregnant patients with COVID, of the 600, about a third of them had a BMI of 30 or greater, so had obesity. 10% had asthma. Just 2% had pre-existing diabetes or diabetes before they were pregnant. A few participants were active smokers, and very interestingly, in our cohort, 30% were healthcare workers. And I think this is somewhat of a skewed population in that it's not like everybody that's pregnant, but I think especially if you think about early on in the epidemic, the healthcare workers and people that were symptomatic or might have had exposures were more likely to be tested for COVID-19 and also more likely to have heard about the study and refer or self-refer. But the great thing about having a very high population of healthcare workers is that the data is very accurate as far as symptoms because they know how to report their symptoms and what we're looking for. Next slide. So for the study, what we did was we asked about the symptoms, and you can imagine when we first started, we had to, as we learned more about COVID, we had to add symptoms. So we gave them a questionnaire with kind of standard symptoms based on the CDC registry initially. And then as we learned about new symptoms, and the big one is the loss of taste and smell that didn't come out for a couple months after the epidemic, that we realized that was a pretty specific symptom for COVID specifically. We added that questionnaire, but from the, added that question to the questionnaire. But from the beginning, we would ask, any other symptoms, and they could fill out, if there was something that they felt that was different from what we had listed. And first of all, fever was very uncommon as the first symptom. The most common symptom was cough, but even that, only 20% of the COVID positive patients experienced cough. Sore throat, body aches were the other ones that followed. And you can see there is a range of symptoms, but nothing was in the majority of patients that tested positive.
So Dr. Gott, to clarify, so how does this compare to non-pregnant patients? Are you going to get into that, or because fever, my understanding, is one of the most common symptoms for non-pregnant patients, and you found that it was different?
I think it's going to be different again because, as we've seen, the indications for testing across the country have been very different. Like in San Francisco, especially early on, we were very fortunate to have access for the general population to get tested. We had very good testing here at UCSF from the beginning, but in many places across the country, there were no tests. And so we always have to keep that in mind when looking at, who's getting tested and what the symptom, because a lot of studies, you had to have a fever in order to get tested at all. And I think that's what came out with a lot of non-pregnant studies in the beginning, that a lot of them had fevers because they had to have a fever in order to be tested, especially as an outpatient. As we are unraveling all of the data that is coming through our study and other studies that are being published, we'll have to put everything together overall as far as kind of testing patterns. And once we have a more complete cohort, we'll have a better picture of what's really happening for, X person with this symptom or not. the other issue that we have seen is that some participants in different parts of the country, they had trouble getting tests. So a lot of them didn't get a test until well after their symptoms had resolved and are more likely to have a negative test at that point. So there's always that caveat as well when thinking about, testing versus not testing and what symptoms you present with. I hope, does that answer your question?
It does, yeah.
Great.
And I think just for our audience to remember, so these were the symptoms, the top 4 that are highlighted: cough, sore throat, body aches, fever, were the most common symptoms found in pregnant patients who tested positive for COVID.
Great. And then the other thing to remember about this, based on the timing of the study, is that the majority of the participants, about 60%, were later in the second half of pregnancy. And so, a lot of these symptoms, for example, shortness of breath and fatigue, I think a lot of times kind of develop over pregnancy as well. So it's always something kind of hard to tease out. But, talking to patients, I think a lot of the patients that did end up being COVID positive expressed that they were already fatigued, but it was like they were hit with something else. It was like a more than the usual. Next slide. And so I think the most interesting finding from this, and this kind of followed us as another study on non-pregnant people as well, is that COVID-19 is more than your typical flu or respiratory virus, in that a lot of patients do have prolonged symptoms, and we do see that as well in pregnancy. So this graph is showing the different symptoms over time, weeks after symptom onset. So based on the time that the patients enrolled in the study and started filling out their questionnaires, and they did questionnaires for up to 4 weeks after the study. Some of them, again, enrolled or started the questionnaires a few weeks after they had already been diagnosed. So they reported, when their symptoms started, and then up to 8 weeks after initial symptom onset, they reported the progression of their symptoms. And you can see that, at the very beginning, again, because in the majority of settings, you had to have some symptom in order to be tested, usually, especially at the beginning, that, almost 50% of patients had a cough. And then this dotted line here that goes up is the percentage of patients that are asymptomatic or had their symptoms resolved at any given time. And you can see this increased over time. So, the symptoms tended to decrease usually within 2 to 3 weeks. At about 3 weeks, you can see that approximately 50% of the participants had reported complete resolution of their symptoms. But I think the one thing to keep in mind is that then there's kind of this plateau where the symptoms can be somewhat drawn out. And even at 8 weeks after their initial symptomatology, about 25% of patients still reported some residual symptoms that started around the time of their COVID-19 diagnosis. And the most common symptoms that were persistent at 8 weeks and after were fatigue in 10% of those participants, shortness of breath, loss of taste and smell in many patients has persisted beyond a few days or even a few weeks. And a lot of patients reported a residual cough. And I think looking at these symptoms, the median time, or the most average time for complete symptom resolution in these 600 participants was about 37 days. So about a month to completely resolve was what was reported for the majority of patients. Next slide.
I want to let you finish because I have so many questions.
And this is just to say, so our priority study has closed enrollment. We have, and this was as of a couple weeks ago, on our study website, we have a dashboard where you can follow and see where our patients are recruited from. And you can see the green dots show kind of where all the different states that our participants have recruited from, the age distribution and how far along in pregnancy they were at the time of enrollment. And you can see we have a great distribution across pregnancy. I see there was a question on, there were a few miscarriages and we are analyzing that data right now to see whether or not there is an increased risk of miscarriage with COVID. I think data from other studies have not shown an increase in miscarriage, and we'll hopefully have that data out soon from our cohort. And as of a couple weeks ago, about 900 of the patients have delivered. And again, these were mostly patients that were diagnosed with COVID in the third trimester. The patients that were enrolled that got COVID earlier in pregnancy, we're still waiting for them to be delivered.
And so, Dr. Gott, did I hear you correctly too, that you said you've closed enrollment now? You are no longer looking for patients to enroll in the study?
Correct. We're following the patients. So the patients are doing surveys at different time points in pregnancy, and then after delivery, another survey, and then we review all their medical records. And I will say, in general, patients have done really well from the data that we've looked at so far.
One of the questions I think that we had and people have, and you kind of alluded to, is do we know what the effects of COVID are on the fetus? So when the baby is still in the womb or in the uterus, or when babies are born?
Yeah, that's an active area of research. I think there have been a couple case reports where there has been relatively convincing transmission of COVID from the mom to the baby during pregnancy. The virus has been found in the placenta. In most cases, it looks like it's kind of in the placenta and blocked from transmitting to the baby, but there have been a couple cases where the baby has had COVID in their bloodstream after delivery, which is somewhat confirmatory for COVID in the newborn. But fortunately, this is very rare. Researchers around the world have been keeping their eye out for newborns born to moms with COVID, and there have been very few cases. Another publication that has come out from the study, we published on the first 200 or so babies that were born, again, early in the epidemic. So again, most of the infections were in the third trimester, and a lot of them, the moms were positive around the time of delivery. And out of about 200 participants, only 2 babies tested positive for COVID. Both were tested positive at one day, the second at 2 days after birth, and both were asymptomatic and did very well, and both were rooming in with their mom and went home without incident. So another series from New York also showed similar findings that, the baby's test may come back positive, but in the majority of cases, they are not sick.
That's great to hear. And we have had questions about what will happen if a patient is COVID positive in labor. We will be answering that with Dr. Gonzalez after Dr. Irani. But just to summarize what I'm hearing from you is that, yes, we have found evidence of COVID in newborns born to the birth parent who was COVID positive. However, for the most part, these babies have done very well. They've been asymptomatic with and long-term sequela, we don't know yet until we look at the data.
Yeah, because of, we're about 8 months into the pandemic worldwide, right? 9 months.
Right.
And so the moms that were pregnant very early on in pregnancy are just delivering. We haven't seen reports from kind of the earlier impacted countries, like from China, for example, where there was an incidence in birth defects. There has not been. And so we don't think that it causes birth defects, for example, like Zika or other viruses. And I think a lot of it will be the long-term follow-up of these babies. And most of them are not acutely ill. But again, for example, other kind of more subtle findings, we need some more time to know if there are effects on the baby.
Dr. Gott, thank you so much. I feel so lucky that I have your cell phone number and I can get these updates whenever I need them. I don't think too many people have that ability, but thank you for sharing. I think it's incredible work that's being done and hopefully reassuring to our patients. There is a question about high risk and immunocompromised status in pregnancy. We will get to that, but to hear that 95% of patients were managed as an outpatient, to me is one of the most reassuring pieces of data from this study. So thank you very much. I'd like to move on to Dr. Roxana Irani. Dr. Irani, you joined our initial webinars and helped update us on our ambulatory or outpatient workflows during COVID-19. Can you explain in general how patients should think about the visits that need to be in person versus telehealth, including the postpartum visit? And as you do that, Bertina is going to share some information with the crowd too.
Yeah, so thanks, Dr. Homafar. So we've worked really quickly, as you know, right from March. Our clinics couldn't close because our patients were still pregnant and having babies. So we changed the cadence and the type of our prenatal visits right away. And we've actually found it to be working for our patients in the balance of video visits and in-person visits. So right now, and I hope that Bertina will be able to share kind of the pathway that we offer, but we definitely want to see you in person when it's necessary. So if ever you require or want an in-person visit, we are happy to offer them. But we have a schedule of video and in-person visits for the low-risk patients, and that might change if you're a higher risk patient. But in general, we offer a new pregnancy confirmation visit, which will be in person and offer you a ultrasound, and then subsequently some video visits, and then an in-person, some video visits, and then an in-person towards the end of the pregnancy. We have found that it's worked really well, that our patients are happy with the video visits. It saves them driving and parking and childcare. So I think that some of the video visit work that we've done here is probably here to stay a little bit. But if ever a patient needs or wants an in-person visit, we have that opportunity in a safe way.
Absolutely. And I've said this before on the webinars, but I continue to say it. I do really think that COVID has given us an opportunity to rethink how we're delivering care. Your safety has always been our priority, but I don't think we've always factored in convenience and actually overall satisfaction and what we absolutely need to do. So one of the things that we are asking our patients is help us with the telehealth visits by purchasing a blood pressure cuff at the beginning of the pregnancy. That way, when we check in with you, that's one vital, one piece of objective information that is really helpful for us. If you have difficulty getting that blood pressure cuff, please let your healthcare provider know. We're happy to help you get access to one. But
and most insurances will cover as well. So insurances will cover blood pressure cuffs for the most part now.
Great. And I've appreciated it because I finally get to see my patients' full faces, because a lot of the pregnancy we go masked, and finally I can see what people look like. On that note, Dr. Irani, what are updates to the visitor policy for patients coming in for prenatal visits? And then I'll get to ultrasounds.
Yeah, so right now it's actually the same for both ultrasound and for visits. Right now we are adhering to the UCSF policy of no visitors in the outpatient setting. In both in our clinic visits and in our ultrasound visits, if there's complications or a procedure that is being done, then we make exceptions to that rule and we'll have partners there. But just know that even in ultrasound or in clinic, please invite your partners to be there on the phone. We have good Wi-Fi, which we're happy to share with you, to use Zoom or Duo or FaceTime or whatever way you'd like to communicate. I've had many visits where I've had like a gallery view like this on the screen with family members. That's totally fine. Same thing, many ultrasound visits I've had with like 4 phones so that grandmas and grandpas can see. We're happy to answer all of those questions. But right now it's the safest thing for both our patients, our staff, all of our providers, to limit the amount of exposures, and that's keeping you safe as well. So we want to continue to do that. As our numbers are rising in the Bay Area, that's going to be especially important. As soon as we can lift those restrictions, believe me, we will. We don't like it any more than you do. We wouldn't do it if we didn't think it was necessary. We do it because it's the safest thing for everyone.
Thank you. Yes, a reminder to our patients that we are trying to do our best to keep you safe. So if you think there is an extenuating circumstance, you are welcome to bring this up ahead of time, but please help us respect the hospital-wide policies and understand that outpatient visits and ultrasound currently do not allow an extra visitor. This is very different from the inpatient side or labor and delivery, and we'll talk about that with Dr. Gonzalez in a few minutes. Dr. Irani, if a prenatal patient has COVID symptoms, what should they do? Is there a number they should call? Should they contact their prenatal provider or primary care provider?
Definitely let us know. What I would say is we've made a couple of changes recently to these policies as we've learned more from Dr. Gau's study and many other studies around the nation that have been published. If you have any symptoms that you're concerned about, could be COVID, call us, let us know. You can call our triage, the OB triage nurse, so the outpatient OB triage. We're happy to help walk you through next steps. We may ask that you contact the COVID hotline through UCSF. If you do, they will help direct next steps as well. In general, for women who are under 24 weeks gestation, so about halfway through, or over 2 weeks postpartum, you can go to any of the respiratory screening clinics that we have at UCSF, and we have many. If you're above 24 weeks or less than 2 weeks postpartum, we'll ask that you come into OB triage for evaluation. And so what we will do is swab you for COVID and make sure that there's nothing else going on that might be causing your symptoms other than COVID, but we'll definitely offer you that COVID test. It's pretty streamlined. We've tested many of our pregnant patients. And if you are positive, then again, we'll help you through those next steps.
Thank you. And I think Bertina is going to give the website for coronavirus at UCSF, the patient hotline. So you'll see that in the chat. We received many questions around visitors, be it grandparents or night doulas, and recommendations around incorporating them in the first few weeks. I'd like to ask all of you, but start with Dr. Irani. How would you approach this?
Yeah, I think it's a really complicated question because family is so important, especially in those first few weeks of having a newborn and being busy. So I think we have to take each case in what it is and figure out where grandparents or family members are coming in from. Are they flying? Are they coming in from a high risk area with high numbers? Is it a long flight? Are they driving? Do they have any comorbidities? What are their practices? Are they wearing masks? Are they physically distancing? Are they super social and not wearing a mask when they are in the company of others? And so I think all of those things need to be taken into account. The best thing you can do is have somebody local, obviously. And if they aren't local, driving is the next best, and then flying. If you can, if they're coming from outside the state or outside the Bay Area, really, we want to encourage people to offer quarantining for 14 days. If you have the means to be able to get a COVID test, the best timing for that is 3 to 5 days after getting off of a plane. And if you have the choice, you should choose an RT-PCR test as opposed to one of the rapid tests that are antigen based. But if you don't have a choice, some test is better than no test, so get it. But if you have the option, pick an RT-PCR. Until somebody is proven COVID negative, masking even in the home, especially because if they're going to be taking care of the baby and you don't know their status, they haven't quarantined for 14 days, then masking until they've either quarantined for 14 days or have a negative test. So it's a tough balance, but you want to keep baby safe. You want to keep grandparents safe because they may be more at risk than anybody. And just being smart about your interactions.
I'll welcome Dr. Ga or Dr. Gonzalez. Do you have anything to add to that?
I agree with Dr.
Sorry, go ahead, Dr. Ga.
Sorry, I couldn't find my unmute button. Yeah, I absolutely agree with Dr. Ani. Everybody's practices are so different and what they, are able to do to reduce the risk from where they're coming from, that it really has to be a discussion one-on-one with each individual family.
The one thing I'll say is if you're bringing a nanny or a night doula into your home, just knowing how many other clients she has and what their practices are and what she's doing in other people's homes. I would encourage masking and regular testing for people who are nannies or night doulas who are staying in different homes or providing care to multiple families. That's a big risk.
And I will add one thing also to that I think a lot of that conversation happened at the beginning, but I do think having regular scheduled updates or check-ins again to see if anything's changed. I think everybody kind of forgets about something, that might have happened or a visit that might have been unexpected. And so I think frequent check-ins every couple weeks as well is prudent.
And I think just being honest about symptoms and you being honest with them and them being honest with you in a reciprocal relationship is really important. And to not dismiss small symptoms because you're embarrassed about sharing. It doesn't matter. If you have a stuffy nose, if you've had even a low-grade fever, important to share.
Thank you. And a reminder too that, I think we all share the same thought about how to approach this, but there are many questions when it comes to care delivery that you ask 5 different physicians of the same specialty, and you might get a slightly different flavor of an answer. But this is one that I think we all agree on. And also, you're welcome to ask your child's pediatrician what they think as well, especially after the baby is born. Dr. Irani, how do you mentioned this, but just to really tease down on it, how would you approach travel during pregnancy, during COVID-19?
Yeah, same thing. Really right now, if it's not essential, please don't go. I know everybody is getting stir crazy. Everybody needs a vacation, but right now is so important when we have to hunker down, especially around the holidays. We're seeing numbers rise, not just nationally, but in the Bay Area as well. So if you don't have to get on a plane, please don't. If you feel like you have to get on a plane around the holidays, travel early and come back late. Don't go in the peak time because your exposure in the airport and on the plane, especially if it's busy, is going to be a high risk. We have a lot of data, even though there's air circulation that happens, it's recirculated air. Yes, it's filtered, but we do know that plane travel does spread COVID. We have many instances of people getting on the plane negative and then being positive afterwards. So be mindful of that. Hand washing, so critical if you're in busy places like an airport or on a plane. Mask the entire time on a plane. And then if you have the ability to get tested 3 to 5 days afterwards, that's a good thing to do. If you want to go somewhere trying to drive and then making pit stops at safe places that you know, or if it's going to take multiple days driving, get an Airbnb that you know and avoid busy hotels with recirculated air and a lot of shared spaces. Hand washing, distancing, masking is going to be key in this holiday time. And when we talk about get-togethers, so for Thanksgiving and Christmas, we try and limit it to 3 households is the guidance, meaning that's not 3 families, that's 3 households. So that could be your family, your brother and his wife, and then your parents. Those are 3 households, even though it's the same family. So that's limiting. Eating outside, doing as much as you can outside and not in closed spaces with closed doors and closed windows is also key.
Thank you, Dr. Irani. I want to move on to one of the questions that had asked about pregnancy being an immunocompromised state and tie it in with one of our questions about frontline workers. Some of our audience members are likely frontline workers who may be interacting with COVID positive patients. We saw the numbers from Dr. Gau's study. How would you advise them to think about work, and how do you think about pregnancy and immunocompromised statuses?
Yeah, so there's definitely shifts in the in our immunostate when we're pregnant. Pregnancy is technically an immunocompromised state, but we don't consider it severely immunocompromised. We certainly have patients who are immunocompromised and are pregnant. If you've had a transplant, if you have rheumatoid arthritis or lupus or other autoimmune processes going on, then you're at higher risk even though you're pregnant. The average pregnant woman does have a certain degree of immunocompromised, which is, I think, in the new CDC data that we've seen recently, about a week ago, they released some new statements showing that while pregnant women don't necessarily get COVID more, when they do, you can have more severe disease, more likely to be hospitalized, more likely to be intubated. And this is new data for us. And so right now, our governing bodies of the American College of Obstetrics and Gynecology, or ACOG, and SMFM, the Society for Maternal Fetal Medicine, which is what myself, Dr. Gau, and Dr. Gonzalez are, we are going to be hearing statements from them probably in the next week or so, hopefully, to get some additional guidance if we're going to make some changes to what we're recommending our pregnant women to do at work. Right now, I would say to continue doing what we're doing. If you're working, making sure that you feel safe in that environment, that you're sure your work has good policies and procedures in place to keep everybody safe, that you have access to masks, hand washing, hand sanitizers, and that you're not being put at risk in the work environment. If you think you are, let us know, and we are happy to write notes. In terms of our healthcare workers who work at UCSF, we feel very secure in our policies. In California, all women can take 4 weeks off prior to their planned delivery date or due date. So we encourage you to do that. We definitely recommend coming out at least 2 weeks before your due date, and really in that 14-day period, really being smart about your interactions and being socially distant and physically distant from others so that you can keep yourself as healthy as you can leading up to delivery. Those recommendations may change as we see new data emerging and new recommendations emerging from both ACOG and SMFM over the next couple of weeks.
Thank you, Dr. Hirani. I want to, in the interest of time, move to on to Dr. Gonzalez. Before I do, one of our patients had submitted a question ahead of time about how these changes could affect how the changes with COVID and shelter, trying to socially isolate could affect rates of postpartum depression and anxiety. So for that individual and others who might be interested, Bertina is going to be giving a list of resources in the chat. If you visit our Women's Health webinar, our Women's Health Resource Center, you will also find support groups that we have always had in existence even prior to COVID that we encourage you to join if you're concerned about anything. And once again, please let your healthcare provider know if you're ever concerned about your symptoms. So I'll have Bertina give you those resources. Dr. Hirani and Dr. Gau, there are a lot of questions, some of which we're going to be answering with Dr. Gonzalez, but if there are any that you'd like to respond to, please answer for everyone to see. Dr. Gonzalez, can you, hi, you are on labor and delivery more than any of us and are directly responsible for a lot of the important changes that have taken place to make sure we can handle taking care of COVID positive patients safely. Can you give us an update on how the UCSF Birth Center, or we also refer to it as labor and delivery, have prepared to handle COVID positive patients?
Absolutely. So ever since the pandemic started, we were actually ahead of the curve. Immediately, we implemented protocols for labor and delivery. It's a high volume unit, meaning that there's a lot of traffic with people. So we've actually put in place policies that limit the traffic on the floor for everybody's safety. We abide by all the UCSF hospital policies regarding masking and hand sanitizing to decrease any potential spread. And as we know, All visitors, including patients, get universally screened when they come into UCSF. So that is kind of our first level of protection prior to reaching labor and delivery. Around the deliveries themselves and our policies within the operating room, we have implemented details on how to handle situations where patients either have a situation where their COVID status is unknown or they are positive, to assure that there is no spread within the unit. Another policy that we have taken in place specifically in our unit is universal testing. Not all labor and deliveries across the nation are necessarily doing universal testing for all patients that come to labor and delivery, but we have made the decision that I think it is very important to know the status of our patients that are in the unit for their own safety and the safety of other patients and the healthcare providers.
So Dr. Gonzalez, regarding this testing, I just want to give our audience an understanding of what's going to happen. If you are scheduled for a procedure, so be it an induction, an external cephalic version,
C-section, any sort of cerclages, any sort of surgical intervention.
Those patients will be contacted ahead of time and they will be given a date to go get COVID tested, correct?
Correct, through the RSC. Mm-hmm.
Okay.
And this test, will be resulted prior to the patient's arrival to labor and delivery.
So our hope is that for patients who have scheduled procedures, we will know their COVID status prior to coming. Now, if you come in spontaneous labor or for an unexpected reason and then require admission to the hospital, we will do a COVID test for you. Dr. Gonzalez, what is the turnaround time for those tests?
The standard is for an inpatient test, it's guaranteed less than 24 hours, but we usually get that test back within a few hours. And as Dr. Irani mentioned, we had a discussion earlier on when the pandemic started, whether we were going to adopt the rapid test or not. But we, as an institution and on labor and delivery, have decided to do the PCR test, which is a significantly more specific and sensitive test compared to the rapid test.
I don't want you to give, not to give us a stats lecture, but what do you mean by specificity and sensitivity?
That is a great question. So the rapid test tells us if you're positive with a rapid test, you're very, very likely positive for COVID. The problem is the rapid test will miss some patients that do have COVID. So it's very specific, but not as sensitive. The contrary with the other technology, which is PCR based, which is just the way a lab technology that is used for the actual test, looking at actual particles from the virus, then that test is actually a lot more specific and sensitive. So we have we can trust that test with more reliability, is a way to think about this.
Thank you. And are we doing this one? I'd like you to tell us about the updated birth center visitor policy. And when I say updated, this is from July, I think, or June. Tell us about that. And are we testing visitors who are coming with the person who is pregnant?
That is a great question. So our visitor policy has been evolving as the pandemic has evolved. Initially, we took a very, very conservative approach because we were very worried about a potential surge in San Francisco. And as the numbers were more reassuring in San Francisco, we introduced a more comprehensive visitor policy. So the visitor policy currently today includes actually one partner or whoever the patient identifies as her support person for the process of labor. And that person does not need to get tested, but does need to pass our universal screening at the entrance of when they come into UCSF. And that person should not switch can be with the patient so you could switch who is your support person, but that the initial person needs to be there for 24 hours. So the earliest that person can switch is 24 hours. The other thing that we have introduced, and this was, with a lot of advocacy and talking to our leaders at the health center, was allowing doulas back, because we firmly believe doulas have a very, very important role in the birth process. So doulas are currently allowed. They do not have to be tested, and they do also need to pass the universal screening process at the entrance of UCSF. The doulas can switch every 12 hours.
Do you need, Dr. Gonzalez, who is a doula?
That is also, doula is a support person that has expertise in helping a mother that's pregnant through the process of labor. We personally do not require any form of proof of certification. It's whoever the patient identifies as her doula. So it's her support person, which is a partner, a family member, or a friend, and whoever she identifies as her doula. Those are the two people that are allowed during labor.
Okay, great.
So we don't require any form of documents saying this is unofficial doula.
Okay, thank you. So to clarify, because we're getting this question a few times, you are allowed one support person and a doula who is also a support person,
Correct.
as long as both individuals pass the respiratory screening test. That is,
the screening in the entrance of at UCSF.
And after delivery or during labor, I know you mentioned that primary support person can switch every 24 hours, but if someone has children at home or pets or wants to go pick up food, are they allowed to leave the hospital and come back?
Oh, absolutely. As long as it's the same person that's returning. And obviously when you leave the hospital, you have to go through the screening process again, and you have to at that time pass the screening process again.
And we are hoping, while we do allow this, we do hope you will try and minimize as much as possible coming and going, understanding that you may be exposing yourself unknowingly to a risk of, you might be exposing yourself to someone who is COVID positive and bring those symptoms back.
Absolutely, absolutely agree with that statement. Yes.
Dr. Gonzalez, are we testing healthcare workers routinely? One of our participants had asked this.
No, we're not testing healthcare workers routinely. All healthcare workers do have to go through the same screening process the visitors go through. And obviously, if they were to screen positive during that process, they will get tested. Or if a healthcare worker was exposed to a patient that was COVID positive and was for any reason considered a moderate or high risk exposure, meaning that somehow there was a deviation from our standard protocols, then in those cases, those individuals will have to get tested.
Okay. And Dr. Gonzalez, I'm aware that the time is slowly ticking and we have a few things to cover.
Sure.
I did want to note to our patients, for patients who are testing COVID negative after they arrive, or if we know it ahead of time for their induction, we are now offering nitrous oxide as an analgesia for labor. So that is something that has also been offered since about July, I believe.
Correct. Initially we didn't, but now we do allow it as long as the patient is COVID negative.
Let's talk for a few minutes. And I think I want to let everyone know, if it's okay, we might be running over 5 minutes or so. If you need to leave, please let me know. Let's talk about the case of someone who is COVID positive. What happens if someone tests COVID positive? Tell us what happens to their visitor policy, if anything changes to their visitor policy, and what they can expect after delivery.
Great. So if the patient does test positive for COVID, obviously we will take novel respiratory precautions. And that means that, we will be taking an extra layer of protection when we go to see the patient. So instead of just wearing a mask, we will be wearing the mask, gowns, and gloves when we interact with that patient that is COVID positive. Regarding her visitor, unfortunately, if that visitor is in the same household, he or she will not pass the screening test because she's been exposed to somebody that's positive. So we urge that that partner or person that lives with the patient assures that he or she gets tested. But in the interim, we would advise to find another support person that has not been exposed to the patient herself for the last 14 days. And so I know that can sometimes be a little bit challenging, but it is for the safety and protection of everyone.
And what about after delivery? Will, if someone is COVID positive, will they be able to continue rooming in with their baby?
Absolutely, and we actually encourage rooming in with the baby. We encourage actually also breastfeeding. And then we alert our colleagues from pediatrics, and there is a separate protocol to test the neonate after delivery.
Okay, and are COVID positive patients able to breastfeed?
Yes, absolutely, and we encourage breastfeeding. Mm-hmm.
One of the questions I meant to ask earlier, and we're getting it multiple times, what is the policy for masking during delivery for the birthing parent?
For the patient herself?
Yes.
Yes, we encourage the use of masks throughout the hospital stay, including during the birthing process. So understanding that in some cases, the patient herself is negative and might not tolerate it. And if that's the case, then we are meaning the providers, midwives, and nurses will be wearing masks all the time. But we also encourage the patients as much as they can to please wear the mask, even if you have a negative test.
So just to clarify, to make sure everyone has heard this, the nurses, midwives, doctors, medical students have always been wearing a mask.
Correct, all the way.
At all times, we're taking extra precautions if someone is suspicious for having COVID positive, so we are waiting for their result, or if they are COVID positive, we are wearing extra gear. And we are asking that the patient and their support people wear masks, especially if there are other healthcare providers in the room. Please be respectful and wear a mask. However, in labor, if it becomes intolerable and you have a COVID negative test, we understand that there are going to be situations where the mask comes off.
Correct. That's completely 100% agree with that statement. And that is what we've been doing on labor and delivery.
Okay. Dr. Gonzalez, I wanted to just quickly go through the vaccine. I think we're probably going to have, when we know more, we're going to have another webinar on it. But Dr. Gonzalez and Dr. Iran, you gave a presentation to our department recently on COVID-19 in the prenatal population and highlighted initial understandings of the vaccine trials. Can you tell us about these vaccines and if and how they may be used for prenatal patients? Do we think they may provide immunity to the baby?
So, one, I can take this if you'd like.
Yes, absolutely.
So, we have, there's many vaccines in trials right now, and just know that the vaccine process for this COVID-19 virus is going at warp speed. So we are actually in 3B trials now for many of the vaccines, and it's going to be a little bit of a race to see who wins. And many of the vaccines look very promising. We don't know yet. Also know that in the clinical trials that there have been, pregnant women have not been included, as far as I know, in these trials for the efficacy of this vaccine. We do know, though, the type of vaccine that they have is similar to other types that we use in pregnancy, seeing as it's not a live virus vaccine. We don't expect for pregnant women to be excluded from using the vaccine. So we think pregnant women will be able to use this. We don't know that definitively though, and we will know that once these vaccines are released. And I don't expect to see it released into the widespread general population, probably until the end of this year, spring if we're lucky, but probably looking into the fall and winter of 2021. And so,
Dr. Irani, sorry, can I pause? So, because you said a few important things here that I want to make sure people heard. So this vaccine will not be a live vaccine, and that is historically been
the barrier for
the biggest
pregnant
limitation
women. Yeah.
For why pregnant patients wouldn't get vaccines. So even though it has not been tested on pregnant patients, given that it is not a live vaccine, we do think that it is likely going to be safe.
I think so, yeah. I'm sure Dr. Ga and Dr. Gonzalez would agree.
Please go ahead. Sorry, I know I interrupted you.
No, I think that's all correct. And like I said, we don't know yet which vaccine is going to be the winner, but all of the ones that we think are kind of on the front line of the trials are not live vaccines.
Okay. And so presumably if we haven't tested it on pregnant patients, we're not going to know if there's going to be an effect on the fetus.
Exactly. And as Dr. Ga mentioned before, the rate of transmission is incredibly negligible. So as it is right now, the chance of your baby having COVID, even if you are COVID positive, is very, very low. And so, but we don't know what kind of immunity that's going to transmit to baby. I can't comment on that.
Okay, because it is something we know for what we call the Tdap vaccine, or the vaccine that protects against whooping cough, which is why we give it to you in pregnancy. But it sounds like this is going to take at least a few years to figure out.
Absolutely, yeah.
Thank you all. I want to take the last few minutes to answer a few of the other questions that are up there. Dr. Gonzalez, a lot of patients are asking, do you reduce the number of hospital staff in the room on labor and delivery in order to reduce the risk of exposure?
We have the standard, it's one nurse for each process of labor. And when we started the pandemic, we did have a reduction in personnel, but now that we're more stable and our numbers remain very low, we have reintroduced some, specifically alluding to our learners, basically, our medical students, nursing students, and nurse midwifery students are back on the unit. I will make a statement that all the policies that we reviewed today will remain in place, including the doula and the visitor policy, assuming that we remain at a hospital level in the green zone, which as of yesterday we have been, which is just a reflection of the number of COVID positive patients within the system. I was in a meeting and we have decided earlier this week that if we reach the orange or red zone, these policies will be revisited, and we will have to, unfortunately, for everybody's safety, take more conservative approaches.
And I think one of the biggest concerns is if we're going to be in a situation like New York City, where we saw that even that one support person was not allowed. Dr. Gonzalez, even from the beginning, when we were concerned that we might be in the orange zone, we were still allowing one support person. Is that correct?
I was involved in all those discussions, and I am a firm advocate that at least labor requires a minimum of one support person. So we will always advocate on that behalf, even if we were in a very difficult situation.
Okay.
Can I just comment that UCSF is, like Dr. Gonzalez said, been very proud that we've been able to safely have one visitor. Know that in the Northeast, many of our colleagues have not been able to have one visitor. And so a lot of pregnant women in the Northeast were laboring alone. And at UCSF, we've been very proud to safely have one person as a support during the labor process.
Can one of you take the question of residents? Because I think I have my take on this, but several people are asking if that will be minimized. I would like to say that residents are an integral part of our labor and delivery, but can either of you speak to whether or not we will be minimizing resident physicians on labor and delivery and in the care of our patients?
I don't think so. I mean, residents, as you mentioned, are an essential part. These are physicians that have graduated. They are just specializing in obstetrics, and they're key actually to the care of everybody on the floor. You know, basically, if I'm the attending physician or any of us four are the attending physicians, we could not be able to take care of the full unit, antepartum and postpartum, without having enough physicians. So I think it is also not only a learning issue, but it's a safety issue for our patients to assure that we do have resident physicians involved in our care team. The issue of learners, meaning students, that is a piece that might get adjusted if we are in a very difficult situation.
Okay. And briefly, Dr. Gonzalez, can you explain why we're asking patients to continue wearing a mask, or advising, I should say, advising them to continue wearing a mask on labor and delivery, even when they test COVID negative?
Well, it is for that extreme situation where the test can still be negative and you could be COVID positive. The test, like with any medical test, is not 100%. The other part could be that we tested you in the very early phase of the disease process when you were exposed, and we might miss the window when you're shedding later. And most patients at least are going to be a few days with us in the hospital. So we still advise you, even if you have a negative COVID test, to mask and take these precautions. I don't know if Ronnie, anybody else has any other comment around that, because I do think it's a very important point.
No, I agree with Juan there. It's for that. Also, you know, we test women 72 to 96 hours prior to their admission. So in that time, if you've had an exposure and then convert to being positive, that's another reason. So we'd ask that after you do get your COVID test, which will hopefully be negative, that you really stay at home and not have any exposures to any outside people.
Thank you. And can you, Dr. Gonzalez, do you happen to know, I think there are a few questions concerning people concerned about the potential cost of getting tested on COVID. Is that something that they will directly see, or do you know if it's covered by insurance?
This should be covered by insurance. It's part of the prenatal care. So I don't foresee, if there are any issues, obviously we're happy to always to advocate on the behalf of the patient. This should not be a separate charge. Okay.
Thank you all. It's 1:07, and I think we have been able to answer most of your questions. There was a question about a patient who I think is wondering where we can reference these policies. I would say to this that we haven't, because this has been such an evolving process, it is not something that we've been able to publish and make available. So if you have any questions about our policies and feel like you haven't been able to get a clear answer, or you are getting divergent answers, please reach out to your obstetric healthcare provider. And if they are not able to reach you, you can always ask to speak to the practice manager or the obstetric or the medical director of ambulatory obstetrics. If you think that it is very confusing, we are trying our best by having these webinars and giving you information on our Women's Health Resource website to try and keep up with the speed of how quickly things can be changing. We encourage you to tune in, share these webinars with your friends who might be delivering at UCSF. And if you think that there's anything we need to be doing differently, please feel free to let us know. Anyone have anything to add to that? Okay. Thank you all for joining today, and thank you to our panelists for their research, their time to prepare for this webinar, and for joining us. We hope you leave with the following: 1, updates on how COVID-19 affects pregnant patients, updates on our outpatient and inpatient prenatal workflows, and preliminary information on COVID-19 vaccines and how they might be utilized with pregnant patients. I'd like to thank Bertina Lee and Verndine Tortorella at the Women's Health Resource Center for helping us put this together. We'd love to get your feedback on how we did and how we can improve our webinars in the future by having you fill out the evaluation we'll send out shortly. It's a beautiful sunny day. I hope you all enjoy some time outside that is socially distanced. Please be safe over the holidays, and let us know if there's anything else we can do for you. Have a good day, everyone.